There have been a number of advances in AML therapy that allow us to give evidence-based recommendations using newer regimens and agents that have led to improved survival compared to standard treatments of old. Recently, data using a liposomal formulation of daunorubicin and Ara-C called CPX-351 improved survival in a cohort of patients between the ages of 60 and 75 compared to standard daunorubicin and Ara-C given as 7 and 3 on that study. These patients all had secondary AML or therapy-related AML, and again, were fit for intensive induction chemotherapy. And similarly, in patients unfit for intensive induction chemotherapy, primarily older patients, a study comparing venetoclax plus azacitidine to azacitidine alone showed a survival improvement for the combination arm, leading to these two drugs becoming effectively the standard of care for the respective populations I've just described. But clinicians have the ability to choose either of these regimens for patients in the older group of patients that are the majority of AML patients diagnosed today. And the real question is, what is the optimal induction strategy, recognizing that outcomes are better with new therapy relative to prior standards, and there's no randomized comparison between these two for patients who might be eligible for either one. Recognizing that generally different patients have been studied, but in the real world, we don't know what is being employed. We wanted to look at large amounts of diverse data, both from our center and also databases of real world data to see what was being used and what the outcomes were in the absence of randomized data. So actually several groups have started performing data analyses like these, and two of them were presented at the ASH meeting comparing intensive chemotherapy to venetoclax azacitidine, and showing what real world differences there were. Now, several groups have started presenting data looking at this question, and our group at Penn, led by Andy Matthews, presented data at the American Society of Hematology meeting looking at outcomes of CPX-351 as compared to venetoclax and azacitidine, using data culled from our institution and indeed beyond our academic center at the hospital of the University of Pennsylvania, a total of 5 Penn affiliate hospitals spanning both urban and rural and academic and community practice. And additionally, used the Flatiron database, which has literally hundreds of academic and community-based practitioners entering de-identified data that can be called for research. So from this large cohort of patients, we were able to make some comparisons. And we were able to identify approximately 217 CPX-351 patients and 439 patients treated with Ven Aza, and then compared outcomes primarily looking at overall survival, recognizing that there were some differences in baseline characteristics as well as the use of transplant. We also performed propensity matching to make comparisons that would be more reasonable based on differences in baseline characteristics that might be expected here. We did see some differences in the baseline characteristics, such as age was older in the Ven Aza treated patients. Prior history of MDS was more common, as well as therapy-related AML was more common in the CPX treated patients. But there really weren't any differences that were notable in terms of cytogenetic or ELN risk group or other important mutations in risk stratification. What we did find is that the survival of these two therapies was essentially identical. There was really no substantial difference in the overall survival, regardless of whether patients had been treated with CPX or venetoclax azacitidine. The hazard ratio was 0.88, and the confidence interval intersected 1. And that was true even when the data were censored for transplant, which was given to approximately 3 times as many patients in the CPX treated group as compared to the venetoclax azacitidine group. Only 10% of patients with venetoclax azacitidine were transplanted versus approximately 25 or 30% of the CPX treated patients. And we did subgroup analysis and showed really no difference based on baseline characteristics, where the patients were treated, what their HCT-CI comorbidity index was in terms of showing a survival benefit for either therapy. They really were overlapping. And even when we did an analysis where we restricted our observations to patients who, based on baseline characteristics, we expect would have been eligible for the pivotal trial of CPX-351, we really saw no difference in overall survival across these two treatments. We did a multiple imputation and probability of treatment weighting analysis, which again is a propensity score matching analysis that allows you to basically approximate what would happen in terms of matching for baseline covariates, similar to the effects of randomization. And basically that eliminates the effect of one group having much older age or much more likely history of MDS, and allows you to really compare apples and apples in terms of baseline characteristics. And when we did that analysis, again, the outcomes in terms of survival showed no advantage for one therapy over the other. What we did see was a difference in toxicity, hospitalization use, showing higher rates of documented infections as well as neutropenic fever in CPX treated patients, and a longer hospitalization stay, not surprisingly, because CPX is traditionally given in the hospital. The median hospitalization stay in data culled from the Penn system, where we really could pour through this with rigor, was 41 days in the CPX arm and 15 days in the venetoclax azacitidine group. So really, in conclusion, what we found was that at this point, we still have no ability to say in a randomized fashion, what is our best therapy, but the available data do represent a significant step towards clinical equipoise, comparing these in a randomized fashion. And already studies that are randomized patients eligible for intensive chemotherapy and who would receive either CPX or 7+3 versus venetoclax and azacitidine have begun, and we will be participating in these studies. And we hope this will further clarify, is there a preferred treatment strategy for patients generally over the age of 60, regardless of fitness, which largely has been our reason for choosing one therapy over the other.